skin becomes more diseased and more stretched, and you get desiccation happening and all of the cracks and openings. You get bacterial invasion before you know it. Then you've got ulceration that you're trying to deal with, and you've got the dermatitis on top of that. The pathophysiology, and you're going to learn a lot about this over the weekend because we're talking about venous disease as well as arterial disease, but typically you've got hypertension in the venous system. So because a person gets up in the morning, the feet go to the floor, water goes to the path of least resistance, which is usually downhill. So if you've got a very large person as well, sitting in a wheelchair, larger around the pannus or hips, you've got a force that's pushing water down, but no way to get it back up. Particularly if they have venous insufficiency or post-phlebitic syndrome in their lower legs, where their valves in the veins no longer work to push the blood flow back up, you get this congestion of tissues. It's got nowhere to go, so it leaks out and it sits in the tissues. I often use an example of like kiddie pool water. So I'll say to patients, let's say you filled up a kiddie pool for your grandkids and put it in your backyard. How many weeks would you leave it there before you change the water? And if you don't, what happens to the water? So we've got patients who are sitting with stagnant water, the water stasis in the lower legs, and we wonder why they're subject to infection and cellulitis and recurrent. So if you think about it too, if you use the analogy of a balloon, so a regular leg, the skin is like the skin on a balloon. If you and I put a pinhole in that balloon, we can't see the hole, but if we decide to make some water balloons for a birthday party, the more water we put into it, two things happen. Not only does the skin stretch, and as the skin stretch, it becomes very thin, and it doesn't take much to break it, does it? You can break it but not only that, but the pinhole gets larger. And isn't that the phenomenon? We get these big congested legs with all this dermatitis on it and all that congested fluid, and we worry about what dressing we put on the outside. And and the water keeps coming, so the leg is almost peeing, and we're trying to deal with the situation without decongesting the leg. We must go back to the pathophysiology. So what happens when you've got this congestion, the skin becomes very, very stretched, the cells break, you get a number of biochemical changes, but most predominantly you get histamine release. Histamine release, that's an inflammatory response, like an eczema or a psoriasis, and it's a dermatitis. So they get very swollen, very itchy, very weepy legs that are very hard to manage, and the quality of life for these people can be horrendous, really. So this is a gentleman that came to see me one afternoon, and we got a call from Emerge. Could we see this gentleman? They subsequently did admit him to the CCU because he was having a pulmonary edema and he was in respiratory distress. But this is a man who had weeping legs. He had advanced CHF, congestive heart failure, so he did get pooling back into the legs, but he also had venous insufficiency. So we had two things going on that caused his legs to swell out. So he came up to our clinic like this. Now he did have an active cellulitis, which they were treating, but he had really pronounced dermatitis, which he said that he had had for years. He said, my legs are swollen. He said, I don't get along with compression socks and I can't do all of that. He was a larger man, did not want. And the biggest challenge with him is that although he had a normal blood flow issue, his legs were always sick. And one of the things that we had to look at was that he had such a poor negative experience with compression in the past to decongest his legs that he didn't want to use any kind of stockings at home. So his legs just swelled and swelled and swelled and swelled, and the mismanagement of some of the CHF contributed to that, but he sat home until he got very sick and ended up in Emerge with the cellulitis. So we had to look at this gentleman and try to figure out how to deal with that dermatitis because his skin was all cracked and broken, and he said it had been like that for years. When we looked at it, we know that the problem with the dermatitis and the cellulitis that resolved from all of that was really a problem that had existed because of the underlying congestion of tissues. So we had to do something to get rid of the fluid. So it's like the stretched out balloon. If you don't get rid of the fluid, the stretched out balloon will never go back, and the skin will never ever be normal. So we had to develop that, and we developed a plan with this gentleman that took several weeks to actually allow us to compress him. We worked with internal medicine to deal with the fluid in his body and all of that, but eventually we got him compressed properly, and we treated the cellulitis, but we also used topical steroids on the dermatitis until the skin and the irritation was resolved. And because the legs were so fragile, we had to be very careful about him developing an ulceration. So we had to be really careful with him in bed, around and how they moved him, around pressure ulcer prevention as well. So think about this gentleman, this is 1 month later, 1 month. Now you think about how desperate his legs looked. I'll just go back to the screen before, look at that leg. That's exactly 1 month later, I saw him in clinic. Beautiful legs. And I actually saw him about maybe 2 or 3 months ago, and this was 2 years ago, and he's still faithfully wearing his stockings. Because what we did, we worked with him to get a program that targeted the underlying disease process instead of just trying to topically try to sort out the problem. Because the dermatitis can be treated with steroids, but the underlying physiology that was causing it was the congestion in the legs.
So if I could just add to that, there's a lot of people who had a negative experience with compression therapy, as I'm sure all of us have spent a lot of time trying to show that. But maybe that's a matter of team building with the people that are doing your assessments who you're referring to for compression therapy, and also educating patients that compression therapy has changed significantly. Even in the past 5 years, it's just incredible the options that are available to patients now for compression therapy. I think there's going to be there's probably a lot of exhibitors. So take the time to go around and see what is available to patients, and make sure that people who've had a bad experience, lots has changed. There's more options.
And I think one of the key messages is when you're dealing with dermatological issues, we can treat topically, and short-term treatment is really important, but we have to understand, are there systemic causes and impacts that we need to address before we ever really deal with it? Because you can have a patient that can have dermatological issues for years and years and years, and unless you get inside the system and deal with some of those things, then you're not going to be able to ever get rid of it or manage it properly. Skin malignancies.
So one of the key things that I dealt with in my community family practice for years, and I still do an inpatient skin clinic at the hospital, so we don't have to trundle people out to a dermatologist to see them for skin malignancy. So I manage a lot of these in the clinic, and the ones I can't, then I have good working relationships with the surgeons and the people at the cancer clinic for possible radiation treatment. So the key thing is that you got to really recognize these. And one of my favorite stories, a lady who was in her 60s who came to the clinic referred for a venous leg ulcer. And she had this lovely ulcer that was just above the malleolus on the medial side. She'd been in appropriate compression therapy for 2 years, and the ulcer didn't get any better. And as a matter of fact, when you talk to her, she says, well, you know, it gets a little bigger every year. And occasionally it bleeds. So when we looked at it, it didn't really look right, and we took a biopsy and she had basal cell carcinoma. So it's really important that we start to recognize these ulcers. So skin malignancies can certainly arise from the skin themselves. So the common ones you'll see there are squamous cell carcinomas, basal cell carcinomas, melanomas, sarcomas, and we've had a couple of those that showed up. Marjolain's ulcer, do you know what a Marjolain's ulcer is? It's a malignant transformation in a chronic venous ulcer. And if you've got a chronic venous ulcer that starts to change a little bit and looks a little bit different, it's really worthwhile to single punch biopsy into that, because we found 3 Marjolain's ulcers over the last 10 years or so. So they do happen. And then one that looks like a fungal infection and isn't is a cutaneous T-cell lymphoma, sometimes called mycosis fungoides. And we used to joke when I was a resident way back that it was the only true dermatological emergency. Because the 2 cases that we followed through the clinic in the last little while, both of them have died from their mycosis fungoides. They had really good treatment, but they ultimately died. And then certainly we can have direct spread from underlying disease, and we can have metastatic disease to the skin as well. So it comes from a distant source. So here's a good example of what happens with squamous cell carcinomas of the scalp. And this has been treated multiple times, and the scalp is a terrible area for squamous cell carcinomas. This fellow has had topical treatment, cryotherapy, he's had Effudex, he's had radiation treatment, and basically he has no skin left on his scalp. And he actually has osteomyelitis in that scalp. So these can be very difficult, and sometimes when we get to our older patients, it becomes even more difficult to deal with them. How do you deal with an extensive squamous cell carcinoma of the scalp of a 95-year-old veteran who is demented, will not participate in care? You just have a terrible time, and often what you have to be doing is a palliative approach to these. This is the leg ulcer I was telling you about. And look at that ulcer. Does it look like a venous ulcer? Not really. It's kind of heaped up. It's got necrotic tissue in the center of it. It has an inflammatory appearance to it. But for 2 years, that was treated as a venous leg ulcer. This is one of our terrible disasters that occurred too. You have to be careful that in people with lymphedema, that they can develop lymphangiosarcomas. It is more common in the upper extremity of breast cancer people who've had mastectomies, but this was in a lower limb of a morbidly obese woman. And I can tell you that this just developed no time flat. I saw her and she had a little tiny purplish lesion. It was no more than 2 millimeters across. It was a little bit hard, but we really couldn't tell what it was. And 2 weeks later, home care nurse called me and said, "You've got to look at this. This is growing." So when she came back into the clinic, that little nubbin that we had 2 weeks ago was now this big around. And we biopsied that. It was a lymphangiosarcoma. And unfortunately, despite multiple efforts, nobody really knew how to treat it. The cancer clinic was essentially flummoxed. They tried radiation, they tried chemotherapy, nothing effectively worked. They tried various other approaches, and basically we ended up treating her palliatively, and she died about 2 months ago. Some people, one of the treatments for lymphangiosarcoma is an amputation, but this woman weighed 450 pounds and would not have survived a hip dislocation and a full leg amputation, which is what would have required. So you need to keep an eye out for these. This is probably one of the more common ones that you will see. You're going to see people with direct spread of breast cancer through the skin, and this is not an uncommon thing for us to see. And then this was a gentleman, one of our patients who had mycosis fungoides. And unfortunately, I have no pictures as it originally presented because it really does look like a fungal infection. So if you've got a fungal infection that's not responding to antifungal treatment, it really behooves you to sink a biopsy into it. Most recently, one that looked like a fungal infection that we were dealing with and we biopsied turned out to be psoriasis. So interesting because it was an unusual presentation. And then this is a direct spread from a lymphoma. And this is a young man who actually refused any actual treatment for his lymphoma. So we do see lots of skin malignancies and we need to be aware of them. So when to biopsy? You know, I'm constantly amazed how little biopsies are done. They are not difficult procedures. I trained a nurse practitioner in our clinic to do them. They do not take a heck of a lot of skill to do them. You just need to know the equipment you need and where to actually take the biopsies. So anything that would trigger you to consider a biopsy is an unusual appearance. Remember that basal cell carcinoma that was being treated as a venous leg ulcer. It had an unusual appearance. It didn't look like any venous leg ulcer I'd ever seen. And so, you know, immediately my suspicion is aroused. The second thing is an unusual location. I mean, when was the last time that you saw a venous leg ulcer on the dorsum of the foot? Unless it's a direct spread from above. You just don't see them there. And we've had several people come to us with a venous leg ulcer on the dorsum of their foot, and they've all turned out to be malignancies. Or inflammatory ulcers, things like pyoderma, for example. And failure to respond to appropriate treatment for the working diagnosis. The working diagnosis for the lady was venous disease. She'd been in appropriate therapy for 2 years. It didn't respond. Time to biopsy. So really 3 key things: unusual appearance, unusual location, and failure to respond to appropriate treatment. So what are the kinds of office treatments that I could do in my office? Certainly not wide excisions. I certainly never excised melanomas. Definitively, what we tended to do if we suspected a melanoma was to do an excisional biopsy rather than to simply punch it. But then that would mean that they had then to go to the plastic surgeon for a wider excision and closure by appropriate means. But excision and suture is certainly one, and certainly I've removed a lot of basal cell carcinomas over the years. with excision and suture. Electrodesiccation and curettage is a very simple approach. In our elderly population, it works better than the excision and suture, and we can just simply, under local anesthesia, do several rounds of electrodesiccation and followed by curettage. And if you curette down to when you stop feeling the gritty tissue, generally you get rid of them. And sometimes they do come back, but sometimes then a second approach with the electrodesiccation and curettage works. It's a simple procedure and it can be done in the office. Cryotherapy. Small, superficial basal cells and squamous cells respond quite well to cryotherapy. The key for people who live in remote areas is Effudex. If you live in remote Ontario or Manitoba or Saskatchewan, what you have available to you is Effudex, and it works really quite well. And the key things that would be a barrier for you to use it is that you have to be sure that people can keep their hands out of it and not get it into a mucous membrane or into the eye. So, I mean, we had a very elderly man in my community practice who also weighed about 280 pounds, and there was no way that we could get him up on the exam table to do anything definitive. So what we did is we treated him with Effudex, and it very quickly resolved the issue in about a month. And then Aldera is also available for superficial basal cell carcinomas. So, Susie, and on to topical treatments.
So the last part of the presentation is about pharmaceutical options. And quite honestly, you know, when I look at it, it's I think that we go back to Dr. Keith's, really we need to make sure that the diagnosis or the treatment matches the diagnosis. And then to have in the plan, when should we know to follow up, or when should we know when to reassess, when the response of the skin condition is not responding to the treatment. So when we look at the different pharmaceutical approaches, I know we have topical steroids, antifungals, and technically there's also topical antibiotics, which we actually don't have up there. But truthfully, we're going to spend more time today talking about the topical steroids. But I did want to just do a little overview of antifungals, just to let people know that antifungals many of them are different. So nystatin is not the same as clotrimazole, is not the same as the nizoral or the ketoconazole or the lamisil that we have available. So one thing is to know that they will cover different fungi, different yeast, and the other thing is to know is when should they be working. So does anybody have an idea of when you're using a topical antifungal, when should you start seeing some sort of changes, some sort of improvement in the skin condition? Any ideas? 72 hours? Not bad. I would actually maybe go a little bit longer. Antibiotics, I expect to see something in 72 hours. Antifungals, probably more like 7 days, 10 days. Sometimes 14 days you want it to continue. Just like an oral antibiotic that you'd be taking. Many times we tell people, you're going to start feeling better in about 3 days, but make sure you take the entire course. So just like that same sort of thing with topical antibiotics, even though you're going to hopefully start seeing some benefit with antibiotics within about 3 days, you might see some improvement, but I would actually tell them to continue taking for the course of therapy. Antifungals, you need to take longer. And again, just making sure that if it's not responding, I would say after 2 weeks, you need to make sure that that person is reassessed to make sure that they're getting the right therapy. Okay, so when it comes to topical steroids, what I really like to emphasize is that, first of all, with respect to, when we go back to Dr. Keith's first slides about skin physiology, really what we want to do is use the topical steroids, not long term, but they really need to get that skin barrier better. Once we have improved the skin texture, the water-moisture balance, we really can stop the steroids. And a lot of times, many people are afraid of using the very high ultra-potency steroids. And actually, I wouldn't necessarily go, but certainly high potency. High potency steroids, short term, get it good, get the skin barrier fixed, and then stop. So having said that, what I wanted to point out was that there are different levels of potencies. Not all steroids are the same. So we have low potency, mid potency, high potency, and ultra high potency. And of course, as you go higher up the ladder, the risk of potential complications, lung absorption and so forth does increase, but it's still very rare, unless you're using huge volumes on a large percentage of the body. So the potency, even within the different potencies,
the potency will vary depending on the site of application. So certainly applying a topical steroid to the arm will be different than applying it to the elbow, where you have a higher, thicker keratinized skin surface, right? And so again, I don't want people to necessarily be afraid of using higher potency agents on thicker skin areas. The skin condition, again, the thickness of the skin, or whether the skin is open, whether it's an open wound or not. The use of occlusion will obviously affect the level of the potency. And patient variation, whether the skin is thin on its own, whether they're immunocompromised. And just to point out the differences, because even I didn't fully appreciate that it's 1,000 times, it can be 1,000 times factor between here and here.
So what do you mean by use of occlusion?
Oh, if you were to put a bandage or a dressing on top. Yes. Okay, so, and the other thing I wanted to point out, now there's so many different topical steroids that if I was to put up the list, the print would be just way too small. But what I really wanted to point out here is that, so we're going to start with betamethasone. One betamethasone is not the same as all the various betamethasones. So most people are familiar with the mid-potency betamethasone valerate. But that's not the same as dipropionate, and by changing the salt part of it, you have a more higher potency. And then by adding a glycol form, which increases absorption, increases the moisture, increases penetration, you'll have a higher potency. So really when we're talking to patients about what are they using, you just want to make sure that we appreciate that they don't just say betamethasone. We find out what salt is involved. And again, I'm using the generic name here because there's so many different brands and different generics out there that I think that if I just use this, and most pharmacies really do have to have both names on the label nowadays. So, you know, once you understand the difference between valerate, dipropionate, glycol, you understand the differences. Similarly, most people are familiar with hydrocortisone. And I apologize, that's actually should have been hydrocortisone acetate is the one that everybody generally knows, which is now available over the counter. So many times you get 0.5% has always been over the counter, but 1% is now available over the counter. So that's a hydrocortisone acetate. Sorry, so hydrocortisone, which is the low potency. Hydrocortisone valerate is actually mid-potency, and that's the hydroval, and that's the 0.2%. Did you have something there?
How long are you going to have to use the ultra high? How long would you limit it though?
So that's a good question. How long would you use the high potency?
Or the ultra high?
Or the ultra high? I would want to use it twice a day. And actually, you know, it's actually in there, but I would pulse it, because you don't want them to use it constantly, because then you get tolerance. So I would pulse it. In fact, you know what? I'm going to answer the question in the slides. And if it doesn't answer then, but good question. Okay, so what I wanted to point out here is that there's different potencies, even though the first name stays the same, depending on how you add the salt part of it, will change the potency. And then, even within the hydrocortisone or betamethasone, you'll know you'll have a cream and the ointment, right? So down here is actually lotions, which are even more drying, but as you go up, or sort of less, you know, spread better so that I should say spread better, spread to the point where it's often a thinner layer. So you'll have different potencies just based on the way in which it comes. So again, thinking about, I guess a lot of times people will think that, oh, that's just a high potency one, but it actually depends on the formulation in which it comes. Okay, and then if we wanted to really get something that's resistant, often what I'll do is if we've been trying to apply it and it's not working, I'll either encourage occlusion, which actually increases it by 10%, or if you put it on after a bath. Right, so you hear a lot of times people say, actually I guess we should say shower. After you cleanse the area properly and you pat dry with a towel, the moisture that you're getting from, if you can attract that moisture, you can increase the absorption by 4 to 5%. And sometimes people will actually put on an emollient cream, before they put on the steroid cream, because that also will increase the absorption. And so a lot of times people will ask me, which one do you put on first, or wouldn't one be diluting the other? But by actually moisturizing the skin before you put it on, you're actually trapping that moisture in and you're getting better absorption into it. Okay, so this is actually, I think, hopefully answers that question a little bit. When you have, so we always will start with the low and go up generally. I mean, everybody will get used to their sense of comfort and which products they like. But generally, if you have, you've been trying to treat a skin condition and the steroid is just not working, of course, what you also would want to do is confirm the diagnosis. But certainly, checking adherence. So many times we tell people to apply it twice a day, once a day, and they're actually not applying it the way they were told to do. And sometimes it's actually because they're afraid of it. There's a lot of times people think it's going to cause the thinning of the skin, or that there's other absorption issues, which technically there are, but that's so rare that often the more you're weighing the risk versus benefit. And the benefit is we really need to get that skin, immune system, physical barrier healed. Once it's healed, you're fine, so you can stop again. Or go back to emollients. So I always do a lot of education around what do adherence and checking on if it was applied, if there was a note saying apply sparingly, how are they applying it? And then, yes, it's possible to get tolerance. So sometimes, in fact, even with the high dose ones, this is the often trick that I'll do. I'll encourage that you apply only twice a day for the 5 days, 4 to 5 days, and then pulse it. So 5 days on, twice a day, and then go to an emollient like petroleum jelly, Glaxo-based, be perfect. Twice a day, and then the emollient when you're on the off days, off steroid days, you can apply that as often as you want, your emollient, and then back on 5 days on, 5 days off, 5 days on, 5 days off. But generally, if it's not responding after 2 or 3 cycles, I'd be reassessing that. Okay, and then you could consider occlusion if you really need to get it to work. Absolutely, especially in really thickened, hyperkeratinized areas. All right. Take-home points. Barbie. Oh, okay. So the take-home points. When considering common dermatological skin issues, and I know that we were trying to it's hard to do a whole overview of dermatological issues in an hour, but when considering the common dermatological skin issues in the healthcare professional's office, it's important to become knowledgeable about pretty much what we tried to outline in the presentation, the barrier function of the skin and the strategies to preserve it, the simple but effective strategies for prevention and management, and the typical signs and symptoms, the diagnostics, and the prescriptions for skin malignancies. Okay, and then I think,
We started off talking about teamwork, that was teamwork in action with the previous coming with the proponents of that topic.
Before I don't get questions, can I just say three things. One in terms of the dry skin and the skin mantle and the hydration of the skin. I was pretty skeptical when I was a young Turk surgeon. This was all tough and nonsense. What has changed my practice is the work that's come out of Australia, where they've actually shown that skin moisturization reduces by 50% the degree of skin tears in residential care homes. And one of the things that's interesting is for me, that was the aha moment of saying, yes, this skin hydration, this skin health is something you should invest in because it can save you lots of money and time down the road. The second thing I'd like to say, and bearing in mind that my practice is weird, because I come from a weird country, is the fact that, in addition to what David said, is if the story's funny, if it looks funny, if it behaves funny, have a low threshold for a biopsy. In my clinic, we will diagnose an unrecognized skin malignancy about once or twice a week. Bearing in mind I'm cleaning off of the unusual stuff anyway. And one of the other things which is alarming, and the paper's gone off, it hasn't been published yet, What we did for other reasons, take a series of 150 new patients coming to my clinic, but we worked them up to have a venous ulcer. What we also did was take a routine biopsy to confirm there was venous disease there. And in about 10% of those patients, when we actually took the biopsy, there was a malignancy. When you actually think about it, or where I was working at, is if you've got a leg wound, and there's a hole in it, if you assess the leg, you assess the leg for having venous disease in it. The lipodermatosclerosis, the atrophy blunt, ankle feral rusted, and the venous stasis dermatitis. And we assume if there's venous disease in a leg, and there's a hole in the leg, then there must be a venous ulcer. But you could say I'm just rubbish as a clinician. But I think that there are more patients out there with unrecognized malignancies than we perhaps give credit to. The third thing I'd like to say is in terms of your steroids, which I think was fantastic and all of that, one of the things I do in my practice and educate me. I need educating. I always use ointments rather than creams because the ointments last longer, there's less preservatives, less perfumes in it.
It's better emollient.
Yeah, unless it's very wet and very painful, I will never use a cream if I've got problems on the thorax. So did I get it right? Questions from you, all you intelligentsia out there. We've got one at the back, and we'll come here. Do you shout or do you mean to run up there?
I can shout. I have kids. When would you use a urea-based product with, say, hydrocortisone or without for patients that have dehydrated skin over Vaseline?
Come on then,
I'm going to tackle that one. First of all, I never use urea creams. I have found them to be horribly irritating to people with lower extremity ulcers, and they actually sometimes promote some erythema. So I played around with these for a long time in my community practice too, and I really came to recognize that the urea is part of a desquamation process, so if you've got some scaling skin, it may help. But frankly, I'm coming to the point of thinking that we're far better to be doing proper cleansing and a gentle emollient rather than anything like a urea cream. And I'm also going to tell you my bias is I do not like Vaseline. Vaseline tends to clog up the sebaceous glands in the skin, and you want that the sebum to come out and form that acid mantle. So you'd rather be using an emollient that like Plaxil base or glycerin. And glycerin is really cheap and is really used a lot in resource limited settings. Very, very useful. So when would I use a urea-based cream? Not anymore, ever.
Did that answer your question? Did that answer your question?
Yes, thank you.
And we had unanimity.
Yeah, no, I totally agree. I find it quite irritating, burning. And urea creams generally, there are creams or lotions, so they're not as good as the ointments.
The other thing just to ask you is there a role for emollients with antiseptics in it that try to reduce bacteria on the skin?
I don't think I've ever actually tried that. Do you have experience with it?
It's interesting in the UK, that's what all the dermatologists use.
Okay.
Is that there are a number of proprietary brands of emollients that have got a low concentration of antiseptic.
Yeah, but I think the problem is that we're running into the risk of having resistance to triclosan. Is that what you're thinking about? Right? So there's a lot of problems we're having with resistance, and there's a certain amount that state that bacteria exposure is actually healthy. Right, you need a certain amount. You know, all those antiseptic hand washes that we're actually having an increased risk of asthma in the kids and stuff. So, to a certain extent, that there's sense less.
Yeah, but when it comes to the UK, we don't carpet.
Certainly you're not stripping off your acid mantle.
I
was just wondering how you thought about using puffers, inhalers, steroids for psoriasis skin, especially around like the osseous and
How does sprays around stomas, if you've got inflammation, yes or no?
I've absolutely, yes, we've all used it, so yes, recommended. Helps reduce the irritation and the
And the advantage is that it's actually sort of a powder-like, so it doesn't interfere with your stoma adhesive and your stoma placement, so yeah, we use them.
Is there a particular one that it's better to use than another?
No, not ventilated.
Flovent is the one.
I think it has to be Flovent, because when I think about it, the other one's steroid.
Is it
Yeah,
steroid?
yeah, the Flovent is a steroid.
Yeah, so we don't use Ventolin because that one.
That's
Steroid inhaler.
And the other ones, there are other ones, but they don't spray out. You have to suck it in so it would work.
Yeah, so
I'll just make the point that it's important to remember that when you're dealing with patients with chronic wounds, that you're a champion for standard care first. And these are things that we consider to be adjuncts. I think the scary thing is if we jump on something like this and we go home and say, oh, I think I know about 5 of my patients that probably have an inflammatory wound or a pyoderma gangrenosum, and I think we're going to flow vent everybody. That's really scary to do because you still want to go back to your standardized treatment and consider Flovent spray as an adjunct. Sometimes if it simply just brings a better quality of life because these wounds can be painful, it may not contribute to the wound healing, but it may contribute to the pain reduction around that wound.
I think that's an important government health warning, is that some of these comments have just been made. Yes, they may well work in experienced hands, but they are not a panacea to be used routinely on every patient you see. If you're getting stuck and you're struggling and you can't access somebody who has an expertise, you may want to think of these things, but please don't adopt it as a routine practice.
So I always like to quote the advice of one of our pharmacology professors in medical school who said, never be the first person to do an off-label use and don't be the last one.
Let's put a question here, then we'll go back to the battle there.
Just to go back to the Vaseline again, sometimes we receive medical orders in the community that says, put Vaseline peri-wound. Would you say that using glycerin would be a good substitute for that?
Is that act as a barrier function?
Yes.
Then I would suggest that you use the commercially available barrier things, basically the acrylates, which polymerize this on the skin and protect it. They're far better than Vaseline.
Okay.
Okay. But that's the one where you're trying to make sure that the epididymis doesn't spread.
Yes.
Yeah.
Well, Dr. Keith, they usually talk about Vaseline for Santo, like we see all this for. No, on the peri-wound.
You don't need it.
You don't really need it as long as you get it into, just keep it in there.
Santal is selective. It will only go after the chronic tissue, so it's safe to use. So you don't need to put a barrier on the skin when you're using Santal.
It can be a little irritating.
Oh, they say it's irritating, yeah.
But if you are going to use it, glycerin or Vaseline?
No.
Probably if you're going to do it for that kind of thing, the Vaseline is a better barrier than
That's the
glycerin.
Just a small area too. It's not like a larger area.
Yes, exactly.
Yeah.
Smaller background.
Right, question back.
You didn't talk a whole lot about the antifungals. Any comments on homeopathic vinegar? Use of vinegar for antifungal feet,
Vinegar.
toes.
Oh, my favorite topic.
You've excited him now, see?
I'm going to suggest to you that you Google Vinegar Soaks. You will get thousands of references. It cures everything. Toenail fungus, just paint the vinegar on your toenails and the fungus will be gone. And then what you can't find is any agreement on the concentration. None. And depending on the concentration you use, your patients will hate you. It stings like crazy. And household vinegar, white household vinegar, is around 4 to 5% acetic acid. And personally, if I was ever going to use it, I would probably dilute it 1 in 5 to 1 in 10. And it needs to be a soak. So you need to soak a gauze in it, you need to compress the wound with it, and you don't leave it on the wound. You go on to some other antimicrobial. It is not bactericidal, it is not fungicidal, it is bacteriostatic. So all it does is it create an acid environment in which it's difficult for the bacteria to replicate. Often Pseudomonas, when you're getting it on the surface of a wound, is a commensal and not an infecting agent. So my suggestion is that you go back to good treatment with good debridement, good irrigation with safe irrigating fluids, and the use of a topical antimicrobial dressing which covers Pseudomonas, rather than do the vinegar. I know sometimes we're stuck because we've tried everything and we think that the vinegar soaks are going to work, but they don't really.
See if I can wind it up. Potassium permanganate soaks.
Oh, goodness gracious. Keith knows that I'm a former chemist. I was a high school chemistry teacher. Potassium permanganate is a poison. And it is toxic to cells. So please don't use potassium permanganate. I saw once where somebody actually sprinkled potassium permanganate crystals in a wound and it burnt the heck out of it. It was just awful.
I've seen a patient who swallowed the tablets orally.
Oh yes.
And all their hair fell out and all their teeth fell out. And they got very funny looking coloured skin.
Oh yeah. Oh yeah. Urusol. That's aluminum acetate. You can get it in sachets and you can mix it up according to that. And Urusol soaks are actually pretty useful for some of those scaly, weepy, lymphodematous legs. They will sometimes, it's an astringent, so it will dry some of that stuff up. Using it for a prolonged period of time, you're also going to then get problems with the barrier function of the skin, but to try and dry up some of that, it sometimes works. So it's worth a try. The problem is finding a dispensing pharmacy that will supply it for you.
It was off the market. In Hamilton, our CCAC had Durasol on our formulary. It was unavailable forever. Durham Borough now is available at Shoppers Drug Mart in Hamilton anyway.
Yeah, well, since each Shoppers Drug Mart is an independent franchise, you'd have to work with somebody in your area. For a while, we were sending people to actually to Kitchener from London to a pharmacy there.
How do you spell that? Urusol?
Urosol. Urosol.
Any more questions? Can we move? You got a question?
Are you picking on me again?
Yeah. I've seen you for months.
I'll come and harass you later.
What about a bleach bath? We had a client recommended to take a bleach bath by a dermatologist.
Heather Orsted has a favorite slide of a very scaly, dry-looking foot that she likes to show. And it's the story that she tells about going in to see this patient and saying to him, well, you must have diabetes because look at the dry, scaly skin that you have on your feet. And he said, no, I'm not diabetic. And she said, oh, you must be diabetic. No, I'm not diabetic. So his wife hauls Heather out into the corridor and says, he's not diabetic. Every night he soaks his feet in Santa Flush. Oh. So, you know what? Please no bleach baths. Bleach is fine for cleaning the tub after you've had a bath, but don't go soaking it.
On that note, that's a good question.
Just quickly, where do you find a place for zinc, or do you have a place for zinc?
Zinc.
Zinc.
Zinc oxide, isn't
Yes.
it?
Yes. Zinc oxide.
It's good for babies' bottoms. And actually we use it when you need a barrier function sometimes with a little bit of anti-inflammatory nature to it from the zinc oxide. And of course that's what visco paste is. It's a zinc oxide bandage, so it's useful in some of those inflammatory legs. But again, I would warn you, with the visco paste you have to be careful. It contains a preservative, and people start to react to the preservative and the visco paste if you use it long enough. So short-term use to settle down a bit of inflammation, it works. Short-term use of the Urusol helps to reduce that scaling and the inflammatory nature, but not for prolonged periods. And that just reminds me, the comment about the high-potency steroids. I mean, one of the key things I used to do with the kids with poison ivy, we would use a high-potency fluorinated steroid, Dermavate is the trade name for it. We would put it on daily for 5 days, and we put saran wrap over it. And in 5 days, it was usually on. But if you're using a high potency, short-term use, great. And then if you've got young adults with poison ivy, don't bother with the topical, just give them a walking dose of prednisone for about 5 days.
There's been some pragmatic primary care visits. On your behalf, thank you, President.